Hi, good morning. I'm honored to be amongst this group of presenters today to discuss the future of diagnostic technologies in Foregut disease. I have no disclosures. Today, I hope to convey the evolution of esophageal testing, describe the current state of testing and the limitations of our current modalities, and provide a conceptual framework to think about goals for testing development. An important disclaimer, like the last talk, is that I'm really focused on esophageal diagnostics from the surgeon's perspective and how we as surgeons apply testing to whether or not a patient needs an anti-reflux operation and what operations should be performed. In line with that, there are many nuances of neurogastroenterology and testing modalities I won't touch on today. By the time you're seeing patients in a surgical clinic, there's a high suspicion or concrete evidence of GERD, and hopefully they've had a PPI trial, and may show up with some of the objective testing listed here. The evolution of these 4 tests really evolved at the hands of surgeons as we learned how to use testing for understanding GERD physiology and surgical decision-making. We won't focus much on the diagnosis of GERD, but I will emphasize the importance of baseline testing for patients with typical and atypical symptoms if they're showing up without a clear-cut diagnosis. The diagnosis can be challenging given the heterogeneity of symptoms, and the sensitivity and specificity of even the most common symptoms is suboptimal. A PPI trial may be nonspecific, and I think this is why testing is really emphasized in the second iteration of the Lyon Consensus released in 2023, where actionable GERD requires conclusive evidence of positive testing in the presence of compatible symptoms. And actual GERD means you're doing something, so you're initiating long-term acid suppression, escalation of management, or considering surgical therapy. When we look at the evolution of testing, we've come a long way from the Bernstein test of the 1950s, where weak acid was instilled to reproduce symptoms. Soon after this, the LES was first characterized with the advent of pressure catheters, which evolved into conventional manometry in the 1970s. In the 80s, GERD moved away from being a lifestyle disease as ambulatory pH testing came onto market, along with the first validated symptom questionnaire and advances in computer technology for ease of reading results. And to put it into context, PPIs were introduced in the late 80s. In the 90s, we saw high-resolution manometry as a huge development, and the early 2000s gave us wireless pH monitoring and narrowband imaging, which helped with reproducible grading of esophagitis. Impedance sensors progressed pH testing past acid to detect liquid gas in mixed reflux episodes, and while the big development of the recent past was EndoFlip, we have not had a widely applicable practice-changing development since. The timeline of anti-reflux surgery is interesting in that most of the operations whose names are common to us originated before significant advances in almost any of the objective testing that we use today. Nissen, Dorr, and Toupet were all performed prior to the advent of manometry and significant knowledge of the LES, although these procedures have evolved substantially since their inception due to advances in esophageal testing. When we think conceptually about the early days of testing, the goal was really to rule in or out surgical disease. It was less to guide who received which procedure, but more so to answer yes or no questions. Testing results were mostly viewed as a dichotomous outcome of whether or not GERD was present on pH testing or whether or not motility was normal on manometry. Looking at the recent past and present, I think we've made significant advancements in putting all the pieces together and defining GERD as a heterogeneous condition that is more complex than just pH. Thanks to testing, we have learned that reflux is a spectrum, starting with the left side here with erosive esophagitis, which is distinct from its neighbor to the right of non-erosive reflux disease, or NERD, which comprises about 70% of the GERD umbrella. And it's characterized by typical reflux symptoms, but negative endoscopy and abnormal acid exposure. This is distinct from hypersensitive esophagus, which also has negative endoscopy, normal acid, but does have positive symptom correlation on pH testing. And then there's functional heartburn, which was an important designation and signifies symptoms in the face of negative testing. Defining these reflux phenotypes was important, but still left us with questions as to how to intervene on each subtype. In fact, the initial anti-reflux surgeries focused more on closing the crura and less on recreating the anti-reflux valve. However, the evolution of high-resolution manometry combined with pH testing, I think, shifted our understanding of the LES. Combining these tests allowed for modalities like magnetic sphincter augmentation and TIF to come onto market, targeting the LES. And FLIP, I think, took this a step further and gave us insight into the desensibility of the LES and how this changes both during and after anti-reflux surgery, including changes with closure of the crura. While not an exhaustive list, some other advances included improvements in patient experience, like with wireless pH probe testing, a better use of histopathology from endoscopy with the discovery of dilated intercellular spaces, which gave us an insight into mucosal integrity of the esophagus, and the application of this is with mucosal impedance test, which tests for these dilated intercellular spaces and can discriminate between GERD and non-GERD conditions. And we do have evolving research on how testing correlates with outcomes, like with PPI responsiveness from these two components within ambulatory pH testing. Manometry is really embodied the saying, you can't teach an old dog new tricks. Now, 3 decades after the development of high-resolution manometry, we are continuing to decipher more components of this old test. Several provocative maneuvers now exist, including multiple rapid swallows, which measures esophageal contractile reserve and has been associated with lower likelihood of post-fundo dysphagia, and the straight leg test, which measures increases in intra-abdominal pressure, where a larger gradient can signify abnormal pH testing. I think Chicago Class 4 in 2020 really signaled a new understanding of several motility disorders with EGJ outflow obstruction and IEM, along with an updated manometry protocol, which included some of these provocative maneuvers. And then more nuanced, but combining modalities has also been a method of progressing technology, as we've seen with contractile segment impedance, which is sort of the baby between high-resolution manometry and mucosal impedance. Despite this increased understanding of manometry and the anatomy of the fundoplication, many took a step back from applying esophageal testing, as RCTs released in the 2000s showed no difference in reflux-related symptoms despite preoperative motility. So while the rest of medicine has been focused on individualized treatment, I think we've taken a step back in anti-reflux surgery, where we still don't have clear answers as to the tailoring of surgery and have 2 camps of surgeons when it comes to the use of preoperative testing for a tailored approach. As we think about what's next, I think we'd hope to address some of the limitations of our current testing. I think what's come out as recent advances feels a lot like the next iteration of the iPhone, where you're wondering what's different and why you spent $800 on it. We haven't quite established a solid role for EndoFlip in the diagnosis of GERD, as there's no reliable threshold for GERD diagnosis, and difficulty with consistent segregation of GERD from controls. We're still struggling with using testing to reliably predict response to our interventions. And despite the Bravo pH technology, we don't have non-invasive prolonged research monitoring past the distal esophagus. So I think if we designate each of these developments as an inflection point of understanding of GERD and motility, the question arises of what's next in line. I think, unfortunately, I don't have any insider knowledge of technology in the pipeline, but I think more broadly, we don't want to be left behind when it comes to using big data and machine learning to our advantage within esophageal testing. I think this will hopefully help to provide a more individualized approach to diagnostic testing, as we still have not reliably answered the question of when and how we should be tailoring surgery and the best test to make these decisions. We've continuously seen a rise in flexible endoscopy interventions, and I think we'll see a paradigm shift towards combined diagnostic and interventional approaches through endoscopy. And testing has to factor in the rise of revisional surgery and how alterations in anatomy impact GERD. I think it's hard to know what disruptive innovation will look like over the next few decades, but the rise of AI should progress diagnostics. Chip technology will also allow for higher resolution chips to be carried on smaller devices, which is especially important in prolonged assessment of extraesophageal areas where reflux may play a role. We've already seen more wearable devices and increases in phone technology to allow for capturing of real-time data and symptoms, and the next stage of this may allow for enhancement of compliance and individualized treatment based on reflux parameters. I think the past few decades we've seen growth and stagnation within the diagnosis and understanding of GERD and its phenotypes. Given GERD's economic impact, I think it's important to ensure an accurate diagnosis and appropriate escalation of treatment, and this is of vital importance to the future of this disease. Under resource constraints, new applications of our current modalities may arise, like we've seen with manometry, but I hope that we see new technology arise that addresses some of our current limitations. I want to thank this group of mentors who taught me everything I know about esophageal testing and have greatly impacted how I've incorporated testing into my own practice. And I'll turn over to the next speaker.